All right. Good evening, everyone. Thanks very much for yet again another One Health class. This is our second class for the semester. The semester seems to be moving ahead, and we just had two classes. Our second class being today, but we're glad everybody can make it for today. We have an exciting guest speaker with us. I will not do the introductions. I'll read that to Chris. But before we start that, I wanted to bring to your attention the Triangle Global Health Consortium annual conference. I sent out an email with regard to registering for that. The different universities have different slots for students, and we know that not everyone from our class will get in for those free registrations. What we want to let you know is we have a Triangle Global Health poster that really depicts the One Health class and how the class came about. And we would like to have the students lead that poster discussion session at the Triangle Global Health Consortium. Ideally, we'd like to have a student from each university, so 3 students, one from Duke, one from State, and one from UNC. However, it doesn't have to be that way. It could all come from one university or 2 from one or whatever. So let us know at the end of this, at the end of today, whether you'd be interested in leading, helping to work on this poster. We have a format, we have a guide, so it shouldn't be difficult. And your names will also go on the poster presentation. The TGHC conference is an amazing opportunity to do networking and really get vested into some of the One Health work. And for the first time, the theme is on One Health as well. So it's really imperative to us that if anyone is interested in this, that we help get you engaged. Yes, I mentioned that registering from your different universities, you might get it covered. And we also will try to, if you decide you want to do this, and you didn't get any coverage from your school, we're going to try and see what we can work out for you, okay? So just let us know at the end of today if you're interested in that, and we'll take it from there. And then the last very brief announcement, and I'll send an email with regards to that, is we talked a little bit amongst some of us at the faculty about incorporating some social media to this class because it's slightly larger than we've typically had. And so for the Monday discussions, we realized we have more than 2 people leading a session. So we're going to be introducing Twitter thing, so each group will do Twitter on the topic, highlighting the key things and a little brief statement of thoughts about what we discussed for the day. And we'll share more details about that. There will be extra credit. We are not going to force you to have to go out and do all this, but if you do it, you get extra credit, and it's a way of really enhancing that networking that we're talking about. So you basically highlight the key things from the talk, things to take away, and try and get people to respond. And depending on the responses, we'll give some extra credit. I will detail all that in an email that we'll send later on this week, okay? So I'll leave that now. This is a new thing, so it's going to be extra credit. It will not impact your actual credit for now, and we'll talk about that in the email. I'm going to hand over now to Professor Woods. And you haven't met him, so he's going to...
Okay, thank you, Mamie. It's good to see everyone. And I want to acknowledge what she said earlier, that we do have a large class this year, which is really wonderful. I'm an infectious diseases clinician, and I was a CDC epidemiologist briefly through the EIS program many years ago. I've been at Duke on faculty since 2002. And I helped start this course at its kind of founding moment many years ago. So I've been involved for a long time. So that's my brief introduction of me. Let me ask a quick question, because I know we have a good distribution of folks from all the different schools. But just real quickly, who do we have today from NC State? Raise your hands, just so Dr. Martin will know. Wonderful. How many of you guys are in the veterinary sciences out of that group? Most of you guys, great. And UNC, who do we have representing? Okay, wonderful. And how many of you guys are in the School of Public Health? Again, most of you, if not all. Okay, great. And from Duke? Wonderful. And I know we have some from BKU on board as well. And how many of you are in the Masters of Science in Global Health? Small number of you. Great. So that gives you a sense, Rebecca, kind of what the distribution of the class is. I appreciate y'all going through that for a moment. It really is my pleasure to get us kicked off for this second class, and my sincere apologies for missing last week. But Dr. Martin and I first met, I think, really in Addis Ababa about 2 years ago, something like that, at the African CDC, which was a really marvelous experience for me. I hadn't been there, but it's a tremendous facility, and it was at a laboratory consortium meeting there, and we got to talking. And my first inclination was to figure out a way to get her up here to join us in our class. She has over, I think you've got 18, you're pushing 20 years of experience. So 20 years of experience at CDC. I believe you received a PhD in international health at Hopkins, if I remember correctly, and spent some time in Boston, developed particular expertise in vaccine preventable diseases, did some work on HIV, worked extensively with CDC in the global programs, but I think particularly in sub-Saharan Africa, and really led the programs during a lot of those very important years throughout the 2000s. And now is the head of the global health program at CDC, and obviously has a great scope of work with that program, much of which is relevant to One Health. And she and I spoke a little bit about how that the overlap of One Health, global health, et cetera, as those niches begin to develop further. And as Mamie mentioned, I think it's exemplified quite well in the Global Health Consortium pushing forward a One Health theme this year. So I think it ties together very nicely, particularly this year, and it's really wonderful to have you up here to join us for the evening. So without further ado, Rebecca Martin.
Thank you so much, and it's great to be here with you this evening. I know it's 5 o'clock, late in the day. It's nice outside, but we'll get through this, and I think it'll be very interesting. We spent the time this morning. I just want to introduce my colleagues that are with me, Dr. Vik Kapil, who's the Associate Director for Science within the Center for Global Health, and Ms. Zukeshi Roberts, who's Special Assistant within the Center for Global Health. So I want to congratulate, but also give them also acknowledgement for putting the slides together with us and the collaboration today. So it's a really group effort. But we spent this morning speaking with the Triangle Global Health Consortium, and it was very exciting to see the bringing together of the One Health and hearing about bringing together agriculture with human health, and also then with food security and some of the nutrition pieces as well, and animal health. So it was very exciting to see this actually in action today. And to discuss a bit is a global initiative, the Global Health Security Agenda, which was launched in 2014, and talk about how it started to bring together animal, human, and environmental health together, and the importance of this in making sure that the world is prepared to detect and respond to public health emergencies and public health events. And go a little bit through about CDC, our role in this effort as well, and in the collaboration. And then lastly, I want to finish by talking about the ongoing Ebola outbreak in the Democratic Republic of Congo, to talk a little bit, again, here is a disease that came from animal to human, but again, how are we able to manage this in some of the geopolitical and context environment that is causing the issue of this outbreak for now going on for over a year and over 3,000 people infected. So with that, I'm going to get started, and thank you again. It's a great honor to be with you, and thank you for the invitation to be here. Where do I point this? I mean, I don't want to poke at anybody here. Yeah. No. Maybe I can do this. No. Or that. No.
Yes.
Should have used the mouse. Okay.
Then I should be able to do it.
Thank you very kindly. I appreciate that. So I want to start a little bit about the context and recognizing what are some of the factors that we're seeing happening in the world today that impacts on global health. And when I'm going to use this term, I mean, it affects the agriculture, it affects the environment, it affects humans and animals. But first, to talk about urbanization. We see more and more, especially on the African continent, but everywhere around the world, people moving from rural areas into urban settings. And it is expected by 2030 that we will have in Africa over 80% of the population living in urban settings. And so this is very important in terms of how do you provide health, and you've got people much more condensed into smaller areas. So urbanization is a critical factor of what's happening and what we will be expecting to see. Also, changing demographics. In Africa, we talk about the youth bulge, where you have now the adolescent population very much growing and figuring out about as they move into adulthood, but also what is their exposure to diseases as well that they may not have been exposed to as children. So as we see the demographics changing, and also in this demographics is the concept of population movement. We see in countries in conflict, we see internally displaced populations. We also see people migrating, and I'll show a slide a bit later to talk about where people are migrating to and where they're going and where they're coming from. But then also to understand what's the impact on countries that may be receiving people from neighboring countries, because this does have an impact on health systems that are not ready to be able to support the larger growth in the populations in their areas. And of course, climate and health is a huge connection that we see in terms of what's happening in the environment. When we see more rainfall, the impact, as we know, on mosquitoes, as we see more difference in drought as well, and the impact on health of the humans as well. And then insecurity and prolonged conflict. We see more countries having areas with conflict, insecure areas, but people are living in there and they have to be accessed for services. So how is that done, and how do you ensure that they are also receiving services? And then access. And this gets to the idea again of, does everybody have access to services? Am I having to walk 10 kilometers, 20 kilometers? Is it right down the road from me? And how do we make sure people have access to services? So this is something that we say quite a bit in terms of, as we know, that within 36 hours, a disease can be transported from any rural village in the world to any major city. And at CDC, we monitor daily, looking at what's happening in the news. We look at what are, as we talked about a little bit, social media, what are some of the events happening, what's being said in different chat rooms as well, to know what's happening out there and what syndromes are being reported, what's in the news, as well as what's being reported from countries through disease reporting systems, through national systems. But recognizing that this is the way that we're living today, and we know this can happen, and the impact can be huge depending on where it is going. So over the decades, there have been many public health emergencies, a lot of public health concerns that we've seen. We hope that from each one, and I say hope because we say we learn lessons, but then sometimes maybe we didn't learn as well as we could have. But I do think we do try to take out, what do we learn from each of these major public health emergencies or events? What are the key lessons that are learned? And how do we improve response for next time? And I say that because now we're sitting faced with Hurricane Dorian, and Bahamas, part of it have been isolated and wiped away. And again, it's like, what could we have done to be better prepared? So there are still lots of lessons that we need to learn to make sure that the world is prepared for the next public health emergency or event. This is where CDC has a global presence, and we are present in over 60 countries. The coloring of the shading in the blue and the light yellow talk about the number of programs we have. We work in programs related to global HIV, AIDS, tuberculosis. We work on malaria programs. We work in global polio eradication, and we work also in other introduction of new vaccines, but also building public health infrastructure related to health security to make sure countries can respond to any public health threat. And you'll see here, this is the number of programs by color, and then the stars are where we have country offices, and the squares are where we have a presence, which may be embedding somebody in a Ministry of Health. It may be somebody sitting within the U.S. Embassy as well. But we try where we can and where we're being in terms of how we collaborate. We work very closely with government. We work with ministries of health, ministries of animal sciences, and ministries of agriculture in a collaborative way in terms of building public health capacity. So to go a little bit backwards to talk about why the Global Health Security Agenda was started. In 2005, this was after SARS, there was a recognition that we needed countries to report for diseases that they were occurring in their borders, that if you didn't know about, were spreading across borders, and nobody was prepared. And so within that, 193 member states of the World Health Organization got together, and I make this sound very easy, but these were long nights, and these were long days. And so it was not overnight that this happened. And it was probably over one or two words. You get into semantics of trying to translate something from Russian into English, into French, and making sure that this word still had the same meaning, because in one it could mean that's allowable, and another it means it's restricted, and another it means you must do this. So you have to think about all this that goes behind this. But they came together and developed international health regulations so that these were the diseases and conditions that countries would report to the World Health Organization, which meant that everybody, all the countries, would be aware of them as well. It wouldn't be kept secret that we didn't know something was growing, and then it spreads into the neighboring countries or gets on a plane and comes to different places. But in summing up the international health regulations, it really is about, can you detect something? Can you assess through your surveillance system, is this going to be a threat and a public health emergency? So making sure, and then reporting it to the World Health Organization, and then responding. And within each of these four words, there are capacities that have to be built. Surveillance systems, the technical capacity for people to be able to conduct surveillance, and then being able to respond, having that surge capacity and the knowledge of how to do that. So in 2007, it was agreed upon that we would start monitoring, and we would give countries 5 years for them to be meet the capacities to be able to be considered ready to respond to any public health threat. So do you think all the countries met in 2012 and all the countries were prepared in the world, all 193? Yeah, no, they were not. And in fact, it was only 33%. So they said, well, let's extend it for another 2 years to 2014. And again, we were still at about 33%. So there is still a lot of work to be done in ensuring that countries are prepared to detect and respond to different outbreaks and public health emergencies and threats. And I say because we are a global community, and so we are only as strong as our weakest link. So this is why it's important that every country work on these issues and work together. So then in 2014, seeing these results, there was a decision to figure out how do we accelerate the implementation of the international health regulations? How do we make sure countries have these capacities built? And out of this came the concept of the Global Health Security Agenda. And this was launched in February of 2014. Now, this was actually before the large Ebola outbreak that took place in West Africa in 2014 and 2015. So it was a snowy day in Washington, D.C. when this happened, but at the same time, it just kind of passed. And said, okay, this is great. But once that Ebola outbreak hit in West Africa, and once people started to realize trade and commerce were being impacted, that people were not able to get their goods out of Liberia, Sierra Leone, and Guinea, that there were border crossings closing, they realized quickly that this was an important concept and we need to build the public health infrastructure of countries and bring together the animal health, the environment, and the human health together. And so this was now has taken on quite a bit and a lot of understanding for the importance of this. And we really talk about this, the global community, as being national security. Because if you don't have health security, there will be border closures. There will be blocks on trade. Your ship sitting out in the port that can't deliver its goods every day is charged a fee. And so that causes to the economic impact on countries. People can lose jobs. Here in the United States, we've done a mapping of over all the states have connections to global work. And so incomes, people's positions can be affected, exports won't happen. So this really comes to national security. And this is the way that we talk about health is very important in this concept. So to date, we have over 67 countries that have joined the health security agenda as of March, and you see those colored here in dark purple to recognize that they're throughout the world that we see this. And what does it mean to have joined? It means that you have agreed to address the acceleration of the international health regulations, that you have agreed to partner with countries. So the U.S., we initially partnered with 17 countries. Most of them were in Africa, but there were some also in Southeast Asia. And we're working with countries to build their capacity to support them as they develop their skills and strengths in these areas. So within the agenda itself, there were developed 11 action packages that you see here in the areas of prevent, detect, and respond. So under the concept of prevent, you have antimicrobial resistance, zoonotic diseases, biosafety, biosecurity of laboratories, and immunization. In the detect arm, you've had building national laboratory systems, having strong surveillance systems, reporting diseases, and building the public health workforce. And then under respond, the creation or the strengthening of emergency operations centers, such that if there was a public health or natural disaster, that they could all come together in one place with command control, meaning there's one person in charge coordinating and everybody's rowing together. And then public health law and enforcement. What's needed for public health laws to be able to make sure that health security is in each country and can remain? And then medical countermeasures, here being vaccines, prophylaxis for post-exposure or pre-exposure. So CDC, in part of this work, our efforts, as you'll see here, are listed what we bring in our expertise to strengthening public health infrastructure in the partnerships that we do with countries we work with. And I just want to highlight 4 primary ones, which is really working on public health surveillance systems, making sure that there are strong lab systems and networks so that specimens from the most rural areas can be collected, transported in a timely manner, tested, and results get back to where they need to go for action. Also making sure that we have a strong public health workforce. And Chris, you mentioned the EIS, the Epidemic Intelligence Service. In the global level, we have worked to establish the Field Epidemiology Training Program, and I'll go into that a little bit later. But it's a very similar about creating those disease detectives in each country to be able to detect. And we worked across animal health and human health in this effort. And then responding to public health emergencies, making sure that you have the surge capacity, you have the skills, and what's needed in terms of thinking about operational research. So here, let's look quickly at these areas in laboratory, surveillance, emergency operation, and workforce that I mentioned. In thinking about laboratory, it really was that we wanted to set a target that 80% of countries that we were working with, of the 17, were able to accurately diagnose pathogens that they wanted to detect. And many countries have up to 18 or 19, including rabies, anthrax, Ebola, looking at some of the influenza, very important ones that they want to be able to detect and be able to test in their laboratory, have reagents. In surveillance systems, we wanted, again, that they were able to detect quickly and catch them as they come forward. Emergency operations centers, we worked with all 17 countries to establish these centers, and more importantly, the role and the functions that emergency operation or operational center plays when there's a public health emergency. And then lastly, in the public health workforce, that there was 1 per 200,000 population, that there was 1 disease detective for every 200,000 population, so there were enough out there that could be able to detect and report quickly. So in many countries, the public health and the health systems have a very important, strong linkage. And we see in these countries that many of the public health functions are embedded in critical care systems. And if I go back to the Ebola outbreak in West Africa between 2014 and 2015, millions of dollars had been spent in strengthening these health systems in these three countries for over decades. But it took 90 days to detect Ebola in Guinea, the first one, 90 days. So you can imagine how people had spread, people had moved in those 90 days. So no matter if you think what kind of a health system you have, you need to have that linked with a strong public health system. They have to work together. And some of the examples are listed here of ways that we work in ensuring that what's delivered through health system, through health care, through a health facility, but needing that linkage with the public health system so that you have people at the lowest levels looking to be able to detect any anomalies or anything new that may occur or any outbreaks that may be occurring. So with the health security agenda, the first thing that is done is to look at a country's capacity. And many countries, as you saw earlier with the international health regulations, they do self-reporting. They'll say, oh, this is my level of performance, we're ready, we're not ready for each of these different topics and areas. But with the joint external evaluation came an opportunity to do peer-to-peer. So it's independent from the government itself. It brings in people from all over the world to come in together, experts, and to work and to review the data of a country, to visit places, and to put together an assessment to identify what are those gaps. And to date, this is from November of 2018, we have over 100 countries that have conducted joint external evaluations, or JEEs, the hundreds being Haiti. And what we surprised us the most is we thought many countries would not want to share their results. Putting your results public to say, we're red in being able to prevent, we're red in being able to respond and to detect. We don't have these capacities. But a country would put that on a website. We were worried because it also is something about, there's political concerns around that. But we were surprised. Every country has posted their results on the website, a GHSA website. So you can go and see a country's level of preparedness in prevention, detection, and response. And this is the first time we've seen this globally, that this is available. For then, once that's done, the country sits down. Now, this isn't done only through the or through the health system. It is done bringing together the ministries of health, ministries of animal health, bringing together environment, ministers of finance, to sit down and look at the gaps in the results, to understand what's going to be needed to close these gaps. And it has to be done together. It's not just a human health issue. It really does require a joint response on this, because we need disease detectives not only for human health, but who's reporting what's happening in animal populations. And that has to come together and work. So the process for the joint external evaluation is that you conduct one. You come together, identify your gaps, and then you sit down to figure out what are the priorities for the country. What does the country want to do? And what's developed is a national action plan for health security. This is the most important part, because without this plan, then nothing will move forward. It's like, yes, we have an assessment. There's been many assessments, but it's really like, how do we put this into action? So with the country action plans, the next is, again, in a multi-sector, bringing in private sector, bringing in public, bringing in academia, non-governmental organizations, civil society, to sit down and say, how are we going to close these gaps? And where are the funds going to come from to do this work? And this is where the commitments come together and country investments. And then you implement, you measure again, and you continue the cycle again about what you need to improve. But over time, and we have seen this since 2014, there have been countries that have made progress in different areas, in surveillance, in their emergency operations center. And I'll give a few examples in a moment. So moving into looking at some of the accomplishments in these areas of prevent, detect, and respond, we have seen of the 17, as I mentioned, priority countries for the U.S. government, 13 countries have improved how they deliver immunization, thus improving their coverage, going out to the communities, doing outreach in community settings, and making sure that they're reaching every child to make sure that all children are vaccinated, looking at children at 2 years of age who missed vaccines and making sure going back and following up to vaccinate them. In the DETECT arm, we have seen 9 of the 17 countries who have built their capacity to detect the pathogens that they want to detect, that they've got reagents, they have laboratorians with skills, and that is sustained. And we have seen this in 9 countries, and this is great progress to be able for them to do this. And then in the area of emergency operation and having trained incident managers who lead a response, we've seen 15 of the 17 countries have trained their incident managers in an emergency operations center, and they have actually activated and had responses and be able to respond rapidly. So again, looking across the 4 main areas that we've talked about, surveillance, laboratory, workforce, and emergency operations, you see here again where we see the progress being made. And workforce development, again, as I mentioned, is one epidemiologist for 200,000 population. And this is where we see the greatest lag, is getting the workforce. And I think you've probably seen this in many of your global health experiences. Human resources is one of the hardest things to sustain and to keep, given how it's done and their lack of systems, and especially career paths for many people, for laboratorians, for people working in the field to continue their work. So I've talked a little bit about the field epidemiology training program, or disease detectives. So I want to go through a little bit why we feel this is very important and what they have been able to do in their countries. Now, people who go through this program, 80% of them remain in their country, which says that they are there to work and they're going to stay. And so it is on-the-job training, and it's to build their capacities in epidemiology, detection and response. We started this in human health. It has moved into animal health. We have worked with military facilities as well as military hospitals, and also thinking about different areas, bringing in different topics as well. But what we really see is looking at how do you provide services to their Ministry of Health in the systems as they develop their skills. And initially, it was a 2-year program that you went through. So you do training, you go back to your position, you come back for further training, and you had different requirements that you had to meet along the 2-year program. But what we found is we really needed to scale up. If we wanted to get 1 per 200,000 population, we had to really scale up and look at what we were trying to do and where were the most needs. And it really is at the front line, in the communities, at the lowest level, that we really needed to have the front line. And so we created a 3-month course and taught them how to be able to detect and how to be able to respond rapidly at the level. And we were able to roll this out quite quickly. And we've trained over 11,000 people now in this. And it has brought a lot of awareness. For example, many have gone back to their communities and right away detected something. I think we have measles. I think we've got meningitis. And sure enough, they have come to fruition that this is really the truth. So they've been able to go right back into their communities and detect and actually report. So it's been very impressive for that work. The next we then developed is looking at the intermediate. And this is a 9-month training, taking public health professionals and training them, again, at sort of the provincial level, the national level. Again, that's the target audience for this. A little bit more on the skills of reporting, on analysis, looking for trends, because maybe in one district, there's only one case, in another district, there's another case, but no one's putting them together. And so somebody looking and saying, this is 2, they're right next to each other, maybe this is a cluster, we should look at this. So teaching them skills like that so that they can start to detect patterns and trends. And we've also kept our 2-year program where we find many people go into this, have also remained in the Ministry of Health, become chief medical officers, become ministries of health. And so we've seen quite a bit of progress, but it's a slow and a smaller cohort that we train in these efforts. So I wanted to just highlight some of the One Health in action that CDC does into our health security initiative. and what have we been seeing? So within looking at a few examples here, in northern Nigeria, there was a lead poisoning outbreak that we saw. We've seen Crimean Congo hemorrhagic fever in Kazakhstan that we've been able to investigate, as well as looking at crowdsourcing for zoonotic disease detection and making sure that there was a response in Thailand. So looking out there, what was going on and how we could look at those efforts. And then, of course, Nipah outbreaks we've seen in Southeast Asia and most recently in India. And through capacity that was built, they had the laboratory capacity, they detected, and they brought in their epidemiologists, their disease detectives to respond. And they did it all on their own capacity and their own resources. So we've seen the evolution of countries having these skills and being able to move forward. I want to go into a few more examples of what's happening in the health security work. And first of all, with Guinea, looking here that they had to figure out a way to get specimens from the rural areas to the national lab for testing and then get results back. And so they created links with the laboratory and looked at ways for moving specimens. And that may not seem like a really big deal, but this, Guinea is a very forested country. How do you move specimens? It's not all by road. So they had to figure out mechanisms to move them and keep the cold chain. And that was very important for those efforts. In Uganda, when it had its first case of highly pathogenic avian influenza, it was quickly able to respond using its emergency operations center, pulling together animal-human health again, and figuring out what was going to be the strategy, how they were going to work at the national down to the community level. And lastly, in Vietnam, I talked about the intermediate level FETP program. And here is where there were cases of diphtheria occurring in different districts, but nobody had put together that there really was an outbreak of diphtheria occurring in Vietnam. And by looking at these data and being able to then analyze and being able to test them, they actually detected an outbreak. If we look at example in Pakistan, we saw very low coverage for vaccine preventable diseases, down to like 10% for looking at measles and rubella vaccine, for example. And so during an outbreak of measles, they were able to go in, interview people, understand what the coverage was, and figure out how to then respond, conducting a campaign to immunize more and more people, especially the children in the community. And in Liberia, where we saw a large outbreak of Ebola, the teams learned how to work with having their epidemiologists in the field, having the strong laboratory, and having the workforce, being able to quickly respond when there was a detection of something. They didn't know what it was. It turned out to be meningitis, and they were able to quickly test that. And then also cholera. I mean, they've been able to use it for many reasons to activate their emergency operations center. So again, working together and bringing all of the different components to be able to solve the problem. This example from Uganda is for looking at yellow fever and shows with building their capacity how in 2010, the yellow dots are suspected and probable cases and the confirmed cases are in white. But you see in 2010, 40 days to confirm the outbreak of yellow fever. And over the years, they've worked on their emergency operations center, building their public health workforce, strengthening their lab capacity. 2016 took them 10 days, and they had 7 cases. And in 2017, it was 3 days, and they ruled it out. So showing how rapidly building health security capacities, a country can really detect quickly, respond, and then further prevent if needed through vaccination for yellow fever specifically. So what we see is by building the capacities through the Global Health Security Agenda, the goal is to have less disease spread, stop diseases where they start, stop outbreaks before they spread further. And this will then lead to making sure that we have economic stability in countries, and allowing then that we have safer and more secure worlds. This is the theory and the genesis behind the Global Health Security Agenda. This is Guinea, and it's looking at 2 points in time during the Ebola outbreak, March 2014 and then in 2016. And the response, the yellow dots or circles are the cumulative Ebola cases. And you see the comparison of March of 2014 to March of 2016, how by building their capacity, they were able to quickly respond, did the contact investigation, were able to follow contacts and to make sure that it did not spread further, safe and dignified burials. But really seeing that faster response led to less cases and less deaths. So in my last component of this talk, I really want to talk a little bit about the ongoing outbreak of Ebola in DR Congo, because it brings together many of the issues I talked about, the context of global health, where we are today, and talking also about some of the capacities that are needed. So we see here on August 1st, 2018, the Minister of Health confirmed outbreak of Ebola in Eastern Congo. And people are ready to deploy to support the Ministry of Health, the World Health Organization. We have a country office, our staff are ready to go. And neighboring countries start to think, well, we need to get prepared, because if a case crosses the border, we're next. And so we need to be prepared. So that response and preparedness modes that have to work together. By June of 2019, we have seen Ebola virus cross the border, 3 cases of Ebola virus disease who were returning travelers from DR Congo who had gone into Uganda, found out that they were positive there too. So who had they exposed in the health facilities, healthcare workers, and being able to do that contact investigation. On June 30th of this year, we now see it spread into Arawara health zone, a different health zone, bordering now Uganda and South Sudan. And we've been working now for over a year with the neighboring countries on being prepared to respond if it's imported. And July 14th, we have the first confirmed case in Goma, which is a very, very urban area, lots of movement into Rwanda, right on the border with Rwanda, and the importance of where it could go next and the spread into. This is an area where people go to Kenya, they go to Rwanda, so there's lots of movement and thinking about what could this mean. And then July 17th, the World Health Organization declared a public health emergency of international concern, or FIC. This took a long time. People kept thinking they were going to do this much earlier, but they were really looking for it crossing into a neighboring country, which it finally had happened in Uganda. But the importance of countries being prepared and being able to respond if there was a potential case or a confirmed case. So this is looking at up to epidemiology week 35 in September to date of where we are with the Ebola outbreak. And as I mentioned, there's over 3,059 cases, over 2,000 deaths, and 912 survivors. And you see the epi curve here of where the cases have been occurring by epi week. We have seen now the continued spread. So people are moving. We saw people going from Beni into Goma, and now moving further into Mwenga and potentially into Kisangani. But we have seen 25 health zones that have been affected by this outbreak. And in the last 21 days, there have been 20 active health zones. So very, very high risk. This area is not a rural area. This is an urban area. These are millions of people in population, which is why it's a very different outbreak than what we've seen in urban settings before, where the Democratic Republic of Congo has quickly shut down the outbreak. This has now moved into the issue of, I talked about earlier, urbanization. More people moving into urban areas and then maybe going to visit or to travel for work. But we have seen to date 136 healthcare workers infected, and we're over 1 year in this outbreak. So why has it been such a long outbreak? And I want to go into a little bit of those details. But one of the main critical basic things that need to be done is when there is a case, you need to go and find all the contacts of the case and trace them for 21 days, taking their temperature daily to make sure they don't have a fever. And if they are, then you isolate them. But getting into communities, this area of DR Congo has for decades been in an insecure area. There's over 100 factions working in this area, and there's not a lot of trust for the national government. So how do you build trust in the community? Working with the Red Cross, Red Crescent Society, they have done surveys to look at how to improve response in the community, how to get the community to engage and reduce the tensions that are occurring with response teams, strangers coming in saying, well, you need to be isolated. I need to take your temperature. Or like, who are you? And, you know, a lot of distrust, thinking that there's 100 different factions operating this. Are you somebody who's a threat to me or not? So one of the two new things that we've had for this outbreak that we've not had before has been the addition of the vaccine and also the use of antiretrovirals, which I'll talk to in a minute. But the Merck vaccine, which is still not licensed, but is being used under emergency use, allows us to vaccinate the contacts of cases, and we also go to contacts of contacts. But again, you have to identify those contacts, and you have to identify those contacts of contacts. So if someone's not going to tell you who their contacts are, you're not going to be able to use the vaccine in a way to stop further spread. But this has been the offering of the vaccine, frontline health workers, and in neighboring countries, Rwanda, Uganda, and also in Burundi, have introduced and have vaccinated their healthcare workers in health facilities on the border to help prevent and be prepared. The therapeutics is the other new thing, and started out with 4 therapeutics, and it was just in August 9th, when they held the Data Safety Monitoring Board, that there was found Regeneron and monoclonal antibody 114 to actually have higher survival rates. And so they stopped the use of ZMapp and remdesivir and are using Regeneron and MAB 114 now as the 2 drugs. So to tell communities, we have a drug if you're ill, and we can vaccinate your contacts. So we have 2 tools that will really help. But again, we don't have the community engagement or community agreement to trust us to do this and to bring people in. And so the importance of how we do this is very critical. And this slide just shows also the importance, as you saw with 136 healthcare workers infected, is how do we stop the infection prevention and control? And this is the training that's needed to go into safe and dignified burial. It's also in the health facilities. But we have to make sure that people who are responding are safe and that they're following infection prevention control to the latest guidelines from the World Health Organization. And as I mentioned, the safe and dignified burials, we've seen more and more that these have been accepted by communities because, again, you don't come in and take somebody's loved one and move away, but it's really how do you make sure that they are still buried in a very dignified way and that they know where their loved ones are buried. We also have talked about this already, is the importance of continuing to track and monitor on the border, the surveillance systems that are needed and that are set up in Uganda, Rwanda, South Sudan, and Burundi to be able to look who's crossing the border, looking for people who are potentially ill, who have symptoms, and reporting them quickly to a system. So these are some statements really understanding about the community trust in insecure settings where this is exactly what is occurring in DR Congo, where we see how do you come in, we have medical countermeasures, we know the government knows what to do, it's done it before in 10 other outbreaks, it knows what to do, but how do you get into communities if they don't let you in? And this is one of the statements from Dr. Tedros, the World Health Organization Director General, and from the previous Minister of Health from DR Congo, just stating that it really is an importance about how do you reach people, how do you make sure that we can bring this in to be able to stop the outbreak, and how do you work with security, how do you work with military in these environments to be able to deliver the treatments and the services. The gentleman in the bottom left corner, he worked with the World Health Organization, he's from Cameroon. People came into the health facility where he was sitting and shot him and killed him. So as teams go in, as we surge our people in an insecure environment, there's a lot of risk. But at the same time, we know that this has to happen and the world has to address the outbreak and stop it. and stop the further spread. We know what can happen, and the importance of really addressing security for the people responding is critical. We've also seen the burning of treatment centers, Médecins Sans Frontières. We've also seen days where communities have shut down and stopped the people from moving, and so we don't see them as well. People are not allowed to go do contact tracing, and again, the spread to continue. So I said this in the beginning, and I wanted to wrap up by showing you what we see in terms of the changes in the world, in terms of instability and fragility. We see insecurity, humanitarian crises more and more occurring, and population movement. And this is from the New York Times, showing in the different geographic areas around the world where people are moving from and where they're going to. And you can see in Asia, many people are staying in Asia, but they're moving in different parts of Asia. In Europe, the same thing. But we see in Africa moving more from the west to the east, and in Latin America with the Venezuela crisis. We see people also leaving Venezuela and going to other parts and other countries in South America. But with that, the population movement, with the urbanization, how do we address all of the health threats coming from animals, coming from environmental changes, coming from what we see in humans? We know that 6 of the 10 known diseases are caused from coming from animals, and 3 out of 4 of the emerging also come from animals. And so this is an area that has to be continually monitored. And with this system, we have to make sure we have surveillance systems that can detect. We have to have people trained that know what they're looking for and to be able to respond, and then the laboratories that can test, as well as then respond if there's an outbreak that occurs. So CDC in general, I just wanted to highlight a little bit of our partnerships. We do not work alone in our work in global health by any stretch. Our main partner, as I mentioned, is with ministries of health in countries, but with academia, professional associations, country governments, the UN, other U.S. government agencies listed here, and philanthropic. But it really does take all partners coming together to be able to address this. As I said, we are as only strong as our weakest link. So with that, I will stop, and thank you so much for your time and attention today.
The question I have wanted to get us started. I'm recalling your original map that you showed of locations and activity currently. The question that always comes up is the CDC expanding or contracting its efforts globally, and how are we currently making the decisions about where to be investing in those particular areas?
Yeah.
Certainly some areas that there was less activity.
Right. Now, a lot of that is based, as I said, with the Global Health Security Agenda. It was the U.S. government. So that was joint decision sitting down with the Department of State, CDC, USAID, Department of Agriculture as well, and sitting down and looking where we could have the largest impact, where was the burden of disease, where was the highest mortality of women and children under 5, and putting all these factors together to look also where did different agencies already have work going on. So trying to see where we could maximize our effectiveness. Now, the funding that we had originally received for the Global Health Security Agenda is ending at September 30th of this year, but we have continued funding for Global Health Security. As we look forward, we look to figure out how we can remain engaged, and we don't want to leave the 17 countries. At this point in time, things are still moving forward. And I show you all this great accomplishments and success, but I do want to say this is very fragile because most of this is coming from funding from outside the countries. If we don't see the domestic resources the government's putting into this to continue it, to sustain it, it will follow, and we have seen that happen in examples of that. So as we think about that, we're looking at how we can be in a more regional model where we can support multiple countries from one base and provide experts also coming from Atlanta or from the regional office to support that. So we don't want to leave the countries we're working in, but what we'll look at is see how we can continue that work in a more regional model going forward. And then we want to make sure that we're represented in the 6 WHO geographic regions as well.
Just to follow up on that, I'm not very sure about this, but I'm guessing that the Democratic Republic of Congo did not have an FETP program. Is that correct?
I have to say they did. They did have a program. I know. Well, and I think this is the thing too, is they had been engaged in outbreak number 9, but again, with the insecurity, if they're not from the area, they were not able to get in as well. I mean, their security as well, just as ours coming in from another country. And so now we've been able to get them into Goma, and they're starting to be able to get in with the security through the UN to support them to get in there. So it's been primarily around the security that they have not been able to get in. But they have led all of the other outbreaks in the past. Yeah. Vic, did you want to add something?
No, I was just going to say the previous outbreak a year earlier was a whole different ballgame. It was in western part of the country, and, and the response and the outcomes were very different.
Has anybody gone through and seen where there's Ebola outbreaks and whether they had FETP training or not?
We've done some of this, and I think that's examples like looking at Guinea in March of 14 and March of 16, and we've looked at Liberia responding to other health threats or potential thinking it's Ebola, and being able to respond. The timing for response is much more rapid, and the detection. That's the most key things we've seen.
Because I think the FETP program does something that's very, very important in terms of the global health security agenda. Because I had the privilege of helping stand up Nigeria's FETP program, which was the first One Health program. I worked on the veterinary side in 2008 and 9. And what I found there is this collaboration where CDC flies people in for 2 weeks of training. They work closely with the CDC office. What it does is it really broadly spreads to good, very, very bright local people. It immediately allows them to become world class.
Exactly.
And they start thinking of themselves as world class, and they start taking on world class responsibility. And it's really a strong model. And of course, if you move to the regional model, I think you may very well lose something there. And so I think that, it's really a good model. I think it ought to be followed more, and its impact ought to be measured more.
Yeah. No, thank you for that. And the FETPs in countries are going to remain, and we want to make sure that we can continue to support. In many countries, we're already on our 9th or 10th cohort. We're looking at West Africa has developed a regional FETP program for a 2-year program, so people can then go back. But it is really critical, and it takes in veterinarians, it takes in laboratorians and medical doctors and public health practitioners to train them to be world class, as you're saying, and then to continue to work in their country because it is their country, they're there, and they need to be able to respond, and they're the fastest ones that can do that. Yeah. Thank you. Oh.
I think there was quite a bit of hesitation to declare, to declare public health emergency this time around. Can you talk a little bit about why some of that hesitation may have existed and how CDC has been ramped up its response to the
Thank you. And I think everybody was sort of waiting for the public health emergency international concern to be declared so that it would give that importance that, okay, everybody, we need to be there. But there are criteria that have to be met in order to declare one. And it wasn't just because it was bad in one country. It had to cross over into another country. And in fact, really, if you look at the criteria, one of the criteria is actually that it has to affect more than one region. And that of geographic region, and that didn't happen. But I think the pressure got so much thinking what could happen now that we had seen cases in Uganda that they did it. And there was also the pressure to do that also was because there wasn't enough funding for the response. But that's also, I mean, when they were looking at it and considering it, it's like that can't be one of the criteria for why we're declaring a public health emergency. But I think many people wanted them to declare one, so that fundraising would also escalate as well. But what it did allow for CDC once it was declared is the U.S. government to recognize that we need to be there. And we have been able to get into Goma. We have not been able to get into Benya, Butumba, where the main epicenter is. A few people, 1 or 2 days, but the insecurity is just too much right now. But we've been able to go to areas. Now that Goma's had cases, we've been able to respond. We've been doing a lot of preparedness in the neighboring countries. And we've also scaled up in the country itself, in Kisangani, and looking also at parts of Lubumbashi, how do we strengthen their preparedness so that if there is a reported case, they can respond rapidly.
Transition cycles in Goma now.
Yes. We've had 2 different importations there, but they both have gone past, yeah.
My question would have to do with the training programs. When you have some people do these training programs, how many sort of cultural barriers are being encountered and how are those dealt with? Is it sort of a local sort of collaboration in terms of sort of making these things like culturally sort of relative in a certain way?
Yeah, no, thank you. It's an important question you ask. And it is. We normally partner, sometimes it's with universities, sometimes it's with the Ministry of Health, but there's always a local partner that we partner with in rolling out this program, and to make sure that as the curricula is being developed, as the students are being selected, that it's done in a joint process and not one-sided, to make sure that if there needs to be representation from many states, let's just pick Nigeria, for example, that's done, because you can't have people necessarily from the South going into the North. And so having to understand a lot of the cultural issues and understanding how the country works, it's important. And so partnering with your collaborators in country is really critical to that. Yeah. You got a question or comment?
So some of my colleagues and I participated with the WHO in the various project. We try to implement lab capacity in various the funding challenges we really want to participate in $80 funds, and then for those activities to stay off. So I guess my question is how do you prioritize the diseases that you want to train for, balance that with some of the priorities maybe they have in the country, and maybe optimize funding to find those country priorities even if they're different than working priorities?
Yeah, and we always start with what the country wants. I mean, they'll usually have between 10 to 18 different diseases that they want to track and respond to. And so we may not be able to cover all 18. And so we look at how a partnership with WHO, with CDC, thinking of what maybe World Bank funding is going to bring in to do, or other partners. But we look at what we have capacities and subject matter expertise in, where we can help do the training. And we also look at what the country's main diseases they want to track. And that's the main driver, is really what they want to do. And within that subset, what subset can we work with, where we could bring our expertise, where we have resources, both human and financial, to do that.
Given the political unrest kind of together species or how do we and global health mediate that? We're trying to intervene Ebola or folks that are when there's this much political unrest in the country, and or what if our State Department has poor relations with the country government? So how can we get that diplomatically to bypass that?
You're going to tell me for the future, because I would love to know that. I think you hit the nail on the head in terms of these are the issues that we deal with. And so if there is, to your point about potentially, let's just say the United States and diplomatically, when we look at other partners, if we look at Pakistan and Afghanistan, for example, we're not going to be wanting to go in and say this is the U.S. We try not to tweet about U.S. there in terms of work. And so it's really thinking of how do we work with the multilaterals. So this is where World Health Organization, UNICEF, International Federation of Red Cross, Red Crescent Societies, and many other non-governmental organizations that do work there, and how they can bring in with their UN system, which is seen as much more of a neutral body, can do that, and how we can work through them. And we have detailed people, meaning we place people from CDC within international organizations within the multilaterals. We've also done remote technical assistance. But I think in some of these areas where it's really hard to get into, we do need to think about how we can use technology to use smartphones. Many places, regardless, they do have service. And so figuring out how can you transmit, many that have created WhatsApp groups and they're sharing information. So how can you get information from those WhatsApp groups as well? And then what you can do remotely in some of these areas where nobody can get there. But you really have to, and also training people who live in the area to be your champions. For example, in Syria, there was a need to train medical doctors to detect acute flaccid paralysis or looking for polio. And they ended up taking some of the medical doctors from part of Syria into Gaziantep, Turkey, and doing a training on what you could detect and looking for different surveillance, making sure they were detecting what outbreaks may be occurring. They went home, and pretty soon, sure enough, they detected a wild poliovirus outbreak. So you have to think about the training, who you're training. Are there other partners that are better able to deliver this in a more neutral sense? And what else can you do in technology? But there's still a lot of work to be done in this area, and I look forward to your brilliant ideas in the future or today as well.
Just to follow on that, I'm still back at the fact that you had trained epidemiologists in the DRC, but they couldn't get there to do the work. That's really breaks down a paradigm that I've sort of learned, which is all we need to do is train people technically. Yep. If they just were good epidemiologists, if they were just good virologists, we could just diagnose the disease.
Yeah.
But what you're describing is a completely new challenge and phenomenon. And it's going to operate in terms of security settings. It's also going to operate in terms of climate. In fact, all there's going to be a number of challenges to really getting the knowledge into the field. Yeah. And it's not just trained epidemiologists anymore.
No.
So is there any effort at CDC to start sending people through like schools of international public affairs, security studies? I'm sure the military is doing some of this, but any comments about, do you need professionals that are sort of cross-trained in security studies?
That's a good question. Right now, I would say no, it's not happening. But I think that, it's an area that you really do need to figure out how civilians work with military, that security information is shared. Because I think, for example, in northern Nigeria, in Borno State, trying to get in to vaccinate children was very difficult. And when you overlaid, looking at the security map of where you knew Boko Haram was, where the military were, and when there were opportunities, windows that you have to be ready to strike. You need to be ready to go in, do your vaccination, and get out. And so these are the things also in areas of conflict or areas of fragile states where you only have a window to get in and get out. You may not be providing daily services, but how can you go in and pulse? Go in, for 48 hours, 24 hours, do all the services you need to do and leave, and then wait for the next opportunity. But it requires coordination between different sectors that normally have not been engaged in health. Yeah. Yeah.
The sustainability of the global health security agenda effort, especially with upcoming end of funding. But I see that as an issue in general with health systems and so I was wondering what CDC has done or what needs to be done to ensure sustainability.
So just to be clear, that what's ending is U.S. government-specific supplemental funding that we received, but we still have ongoing global health security agenda funding through our government funding. But I think it's more important for sustainability is not what CDC does, but what we get countries to do. Because we really need countries to own the work here, that there's room made in domestic budgets, and that, as I said at the beginning, that they see health security as a national security, so that the importance of monitoring it and having an indicator that's monitored by the president or by the prime minister, so that there will be funding for it, are really critical for the sustainability. And that it's multi-sector, bringing in private sector, bringing in public, bringing in non-governmental organizations about how do they work together to do this for the sustainability is important. And so we do a lot of work and awareness and bringing people to the table for these discussions as well. It's very critical. Vicki, you wanted to add something?
I was just going to make a comment and follow up to the issue that a couple of people have raised about working in difficult environments and insecure environments. And Rebecca mentioned one example here about, I think you mentioned Pakistan. Mm-hmm. So we very recently had, there's been an outbreak of HIV infection, which you may have heard about in Pakistan and province. A lot of it impacting kids. And one of the ways that we were able to engage in that is we had a couple of subject matter experts who connected with the WHO team and were able to go into Pakistan in province. And it wasn't just an issue of them going to Pakistan, because Pakistan actually is fairly welcoming of Americans to come and help that kind of situation. So also lots of restrictions related to security and things like that. And, but they were able to do that working with WHO, so working with a multilateral partner. Another very important route is professional organization. That's one area that sometimes we often forget. So another example of that is chemical security and chemical exposure. So the State Department actually has a chemical security program, which they support in target countries. Now the issue for us, and this isn't directly CDC, but it's with some of our partners. So how do you do education related to chemical exposures in places like Iraq and Yemen and Afghanistan? It's very, very difficult. We can't have a team there. So one of the partners, the American College of Medical Toxicology, is actually organizing a program right now with State Department funding in Turkey. And so all those regional target countries like Iraq and Yemen will be sending people to Turkey for that training, which will be conducted by the American College of Medical Toxicology. So it's kind of this very circuitous way of doing it, but you have to become very creative when you're dealing with these kinds of challenges. And there are a lot of professional organizations very active and very willing to work with USGH students.
That's a good point, yeah. Yes.
Can you talk about the role of the CDC and the public health community in general in advocacy against conflict? Because when we talk about the difficult operating conditions of a country like Democratic Republic of Congo, it's indeed the case that conflict is making it much harder for all of us to do our jobs. And so it seems like there must be some kind of conversation between those who are on the ground and then those who have some kind of leverage about what's going on in these conflicts. I recognize that it's very hard in DRC. There are so many different groups. But I would say I think the UN has been reasonably successful in places like Yemen, where they place pressure on the Saudi coalition and the Houthi group to sit down and talk, because both sides are bombing children in hospitals and all these crazy things, and it makes it, again, difficult for public health to happen.
Right. No, and I think this is what CDC does and public health agencies is bring the information forward, make lawmakers, make policymakers, make UN aware of the situation and what's needed, but we don't do anything directly. in this area, but it is providing that information, letting them know the importance and the seriousness and the concerns that this could spread and those larger consequences. But then it really is how do you bring leaders together for Africa and the Africa Union? How do you get that at the High Security Council table to have that discussion? And that's where, us trying to talk about health security as national security, because countries get national security, leaders get national security. And so the importance of being able to talk about it in that language and the awareness. But then we really do have to leave that to within the U.S. government, our State Department officials, but then also, as you said, the UN, the Africa Union leaders, and identifying there's also economic communities that can put pressure. So that's another group that you can use depending on the economic communities. There's many in Southeast Asia, there's many in Africa that are also opportunities to figure out how to share this information to be used in a way to help address the concerns.
This is a follow-up to that, which I thought was a great question. As an epidemiologist, always I like numbers, right? Could you calculate DALYs, or some kind of measure of impact for, an epidemic in a conflict zone versus one that wasn't? And then have you ever done anything like that?
I haven't seen that. It's a good question, though. I would be interested in looking at that. Yeah, we haven't done that, but I'll maybe do a search and look for that. Yeah.
That would be very interesting, because that would be a real measure of conflict and the impact of conflict.
Right. Yes.
I'd like to probably do the ask questions in the chat room, and it's posted up there.
Oh my gosh. Okay, here we go.
So it says, I'm going to read it again.
Yeah.
Ebola outbreak in the DRC. Our country share information with each other about suspected cases. Is there a regional emergency operations center where this information is monitored and shared?
This is a really good question. And you would think, sure, there's a regional emergency operations center. Many places, the Africa Union, Africa CDC has created an emergency operations center. But what it comes down to is really, Rwanda and Uganda and DR Congo, there are some political issues occurring as well. So sharing information took a long time. And so on the border it was happening, but not between national governments. And it was about 5 weeks ago, there was a meeting where they brought together the ministers of health of these countries, and they sat down and talked about how can we share information? How do we make sure this is happening? So something where you think would be important, and it is important, how do you make that happen? And you have to pay attention to that, because the cross-border work is really critical, and that the information is shared between and among countries, not just for the country collecting it. It's really critical. So it's a very good question. And now there are efforts to do that for the current outbreak, but for each outbreak, you need to start to look at that. But there is no regional emergency operations center at this time. It's a good idea. We could suggest it. Yes.
Going back to that you made earlier, there were concerns that perhaps the regional model may diminish the impact and the empowerment that we have with those countries and those individuals on the ground level. Is the CDC planning to maybe increase its presence in those locations in the regional model to compensate for that? Well,
I think that's the ultimate goal, is to, as we start to look at where we're going to be based in our regional hubs, to think about what's needed in that workforce. Do you need an expert in viral hemorrhagic fevers? Do you need an expert in, what specific laboratory that can help build national public health laboratories? So it really is to think about that down the road, about how do we build that expertise that then can be provided at a real-time basis, as well as when there's an event, that there can be that surge capacity on the ground already to go and support the countries as needed. So that is the goal, is to think through this. But right now we're building the models. So. Yes.
My question is about the vaccine that is actually in use. Do you have any preliminary data? I'm assuming that it's being studied closely about its efficacy and nasal presence, but if you would be able to comment on it now.
Yeah, no, both when it was used in Guinea, they found, over 95% vaccine effectiveness. And also right now, they're also reporting very high vaccine effectiveness with the vaccine. It's still under clinical trial, so the data are all with WHO at this point in time, so not everybody has access to look at that, but they are reporting out that they're very good efficacy and good, if it's given to contacts early. If contacts have been exposed from the case already and it's in more than 10 days, less vaccine effectiveness than if it's shorter than 10 days of exposure. So that's really critical, but there has been great. Then there was the whole issue about, and you saw on the slide, do you give it to pregnant women and children under a certain age? And the strategic advisory group of experts with WHO on immunization had many meetings on this and agreed in these situations that you would want to give it to pregnant women. You would want to, but at the same time, if the baby dies or the mother dies, the community now thinks that you're trying to kill people in the community. And so the communications around that as well is so critical. And so important. There's another vaccine, Johnson & Johnson vaccine, which is given at the first dose, and you have to have a booster, and it's 58 days between the two doses. So it's really not to be used in the outbreak setting because you've got to go back and find that person again. They need both doses. So that's being looked at how that can be used in areas more as a preparedness among healthcare workers. So that's also being looked at, and they're doing a trial in Uganda right now. But there's no vaccine effectiveness on that right now.
So am I right for including in this kind of current outbreak with the advance of the vaccine and the other therapies? So the difficulty here could have been a lot smaller, but it's security and the future of producing Western Europe.
I think, we're making a lot of suppositions, but I think that in theory, yes. I think that would be very much the case where insecurity is making it difficult for people to get in to really see and know what's happening. And then the issue of making sure that these communities that have no one's ever visited them or it's been a lot of different factions, so who do they trust? And at that time as well, and it was on the slide, is they stopped holding the national elections in this area, which then, just infuriated people. It's like, now we're being cut out. So, there's so much distrust and rumors abound. And without being able to control and being able to have that public health message to counter it in that same media, it's an opportunity for this to spread. So we really do need to, as we talk about getting to the basics, is understanding when a case is detected. Is it detected in the community, or is it detected by somebody who's come into the facility or through a contact? And then how do you make sure that you know all the contacts, that you can vaccinate them and ensure infection prevention control, both with deaths in the community and with healthcare workers in health facilities?
Is there anyone that you need to look at? What is the country which is a priority? And what makes that country, what do that country feel in their best interest, but they are off that part of the one thing to say no, but go there,
This is a good question, and our goal is to, as countries, build that capacity, that they have their own capacity to do this. And the joint external evaluations, we didn't show any of the scorecards, but as countries move from potentially, let's just say laboratory, they move from red, meaning that they're not able to, they don't have reagents, they don't have laboratorians, they can't detect. As they move then to a yellow, well, maybe now they have laboratorians, they have some of the reagents, they can detect 50% of the pathogens they want to detect. And then they go to green to be able to detect 100. So as countries move, as we say, from the red, yellow, and green in the 11 and technical areas, we would see that is, then they are self-sustaining and able to move forward on their own. And we've seen countries achieve this in different areas. But we see, not anybody is 100% there. Even the United States, we did our joint external evaluation, some of the antimicrobial resistance and the communication across U.S. government agencies. We did not have a perfect score by any means. So I think that's there's always improvement, but we do want to see countries own their responses, own their preparedness, and also the budgets, put the money forward to be able to do this, and as they move off the list. Yes?
I know we've been talking a lot about emerging infectious diseases, but I think we're also seeing a resurgence in like measles in many places that have vaccines, due to vaccine hesitancy and other things. The Center for Global Health and CDC working on, trying to help countries identify those outbreaks early and try to combat vaccine hesitancy as well.
Thank you. It's a great question. And I think one of CDC's, I always talk about CDC as the strength of CDC is its people, our subject matter experts that we can bring. And we are an evidence-based agency in terms of using data to drive programs, to drive decisions in programs. And we do quite a few risk analysis. And with measles, we have been working with WHO, and we've been working with Gates Foundation to do risk analysis for many of the countries. And these risks have been identified, that there have been cohorts where we know children have not been vaccinated, and the potential, if measles virus was introduced, that it would spread rapidly and fast. And so we've known this, but so it's always that point of like, things, but then how do you get to action? And trying to invest in prevention versus response. Prevention is much more effective, much less expensive, but that takes time, and if you don't see things, people don't remember that it occurs. But the other thing we're doing with measles outbreaks is with the misinformation and disinformation occurring. We've been talking, and so is the World Health Organization, with Facebook, with Google, with Pinterest, about how do you move up those sites that are science-based and evidence-based information about what measles is, why you need to be vaccinated, as well as working with countries because they need to be able to do the risk and crisis communication. There's sort of that continuum of vaccine hesitancy to those you will never convince who are anti-vaccine, but there's that middle and proportion of parents and guardians who believe that maybe I shouldn't get my child MMR, but definitely they should have polio, they should have hepatitis B. So it's not for all antigens. It may be for one or two. So with information, correct scientific information, how do you convince parents and guardians to vaccinate their children? And as we see the resurgence of measles here, even in the United States, among communities, and that people die from it, it's not just a mild disease, people die. And how we can help communicate that is really critical. So that's something else that we're working on.
Just a follow-up, and to that question and the response that you're working with Facebook and Google. If you, for example, had some information that you wanted to get out, would it immediately go to the top of Google's algorithm or with Facebook and immediately make sure that more people saw your response as of today?
As of today, I don't know where it is in the process, but I know that there's under discussion, and I know with WHO, yes, that WHO has already implemented some measures with Facebook and Google already on that front.
So that their information,
their information would appear first, yeah. Changing the algorithms and some of them.
I guess if it's not currently that way, after today's action by 50 state attorney general,
it will be, yes. Yes.
You talk a lot about people nationally critical health security, but I'm just curious, what is CDC doing, or what are we doing domestically in terms of global health security? Like, are there major changes going on in our own family stuff, or I know we have here and a lot of times where even people here express internationally travel, we're going to need to do that. So,
no, thank you for that. And CDC, I mean, being the U.S. government agency to protect the U.S. population, absolutely. And Dr. Redfield, our CDC director, is very supportive and main priority looking at the domestic preparedness while building global health capacity for health security. And so working with states, who is our main partner that we work with in building up the systems and preparedness making sure counties and within states have that capability and the systems that are needed. We're also working on how to improve having access to real-time data and making sure that that can be available at the state level and across states as well, not just across countries. Vic, I don't know if you want to add anything to that. Yeah. But
it's a huge priority.
Yeah.
And in fact, Dr. Redfield, the CDC director, is often saying that there are many reasons where making global health security work, but one of the major reasons is also to protect Americans at home and abroad.
yeah.
Great deal about them.
Stop diseases before they get here, but also know about them, know what's emerging so that we can protect the U.S. population. And then working, as I said, through state health departments and key professional societies, as well as Vic mentioned, are really critical in the structure for that.
Thank you so much. I think we're going to stop the question session now, and then the last 20 minutes or so for the freedom section.
You know that so we'll take a 5-minute break now. Before that.
Yeah, before that, I think that might have